Afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We're delighted that you're able to join us virtually today for our next webinar. The Trust is pleased to once again partner with Dr. Sarah Smucker-Barnwell and Margot Adams-Larson to present these telehealth community chats. They've done a tremendous job with this series, and I know I and our policyholders appreciate their expertise and the time and effort that goes into putting these together. I'd also like to take a second to remind you that the CE earned from our chats can be used to fulfill SIPAC's 3-hour CE requirement for your e-passport renewal. If you're unfamiliar with SIPAC, which stands for the Psychology Interjurisdictional Compact, I encourage you to visit their website at www.sipact.org for more information. I hope you enjoy and benefit from our telehealth chat today. Please join me in welcoming Dr. Smucker-Barnwell and Adams-Larson.
Thank you so much, Dr. Martin, and thank you to the Trust for having us today. And thank you to everyone who has joined us. Margot, it's great to see you, and I'm excited to talk telehealth once again.
It's great to be here, and I'm so glad we're back because there has been a number of things that have happened in the world since our last chat, and we will be getting into those shortly. As a reminder, we do these as a quarterly check-in, and we don't use slides for these. We prefer these to be more conversational. You can drop in the Q&A box your questions that you have for us today. And you certainly can email questions ahead of time or drop them in the evaluation as well. We really try and focus on the practical how-to information about ethical perspectives and clinical practice in our content today. And I'm really excited to dig in. So with that, should we get started?
Without further ado, I think we're starting off today with some news, things that have happened in the last quarter in the world of telehealth that we hope to share with folks who are here with us today.
Well, and maybe this first one actually is a bit of old news, but something that we had some questions that came in on, and that's about the Cures Act and good faith estimates, or No Surprises Act is another term for it. It actually came into effect in January of 2022. So it's been around a while, but I think with some of the questions that have been floating around, this is one that has come back up to the surface, and just some general guidelines and ideas. The Trust has a great frequently asked questions, FAQ, on this on their website. So you can definitely go over there and check out a lot more detail than what we're going to just cover real briefly. But in general, this act came into effect, and really the basis was to help folks who either don't have insurance or who are planning on self-paying for medical behavioral health care services to have knowledge ahead of time when they're scheduling their appointment as to what those costs might be that they would be incurring. And so there are guidelines around when you need to provide that estimate for them. How and when those details are may vary based on your state, because your state may actually have some laws that apply to this as well. And there may be some distinctions if you're in a group or a solo practice versus if you are working in a large healthcare entity or a facility. And so there are some differences in the timelines of when those estimates have to be provided or how they have to be provided. We're noticing a lot of that electronic health records are kind of rolling out a process to make this fairly easy for folks to both from the patient portal side request an estimate, and from the provider side to provide that. I think the other thing to know about this in general is any of these estimates are actually covered by HIPAA and become part of the medical record. So they're not the same as maybe you might think of in service documentation. This is actually something that does have to remain within the medical record for the person that may actually not end up showing up to your session. So just an alert to look around and to be aware of those primary circumstances. You can get a lot more information if this is a topic of interest to you on the frequently asked questions on the Trust website. So I will conclude that and turn it over to Sarah for some CMS Medicare updates.
Boy, it's the good faith estimates are an example. I found it a little daunting when CARES Act first came out. I thought, okay, I have to go through and do this, for all my cases. But I will say that it was a clinically helpful examination of revisiting my treatment plan, being really thoughtful of, are we on track, and I think, there are lots of rules and they're all there for good reason. And sometimes, you really feel like, okay, well, this really aligns with good practice in a way that feels nice. And I think that's one of those moments. But yes, on to CMS Medicare facts. So the Center for Medicare Services, or CMS, has a very helpful fact sheet that they put out related to telehealth. And there were some updates recently, which was newsworthy, and it's all pretty good news. So, in the context, a little bit of history, in the context of telehealth days past, it was once the case that in order to receive remote services for any healthcare, and specifically for behavioral healthcare, you had to live in an adequately rural area. So there was kind of an index of how rural where you lived was, and did you meet the requirement in order to be eligible for telehealth services. In the pandemic, there's already a trend actually before the pandemic of loosening these restrictions, but the pandemic really hastened a lot of that. And we saw the removal of those requirements and allowing more people to have access to telehealth services that were covered by Medicare. So this is relevant to Medicare recipients only, but as we know, as Medicare goes, often so goes private insurance. So it's really worth kind of keeping an eye on what they're up to. So anyway, Medicare came back and recently said, okay, well, up until December 31st, 2024, we're going to keep this policy of all patients can access telehealth without any of that specific requirements about their originating site or where they're receiving care. No geographic restrictions. We're still going to go into people's homes, things like that. And even after that date, after December 31st, 2024, with a few sort of clinical conditions being met, and I'm sure as we get closer, they will articulate those for us. It is the expectation that they're going to keep on allowing that more permissive coverage of telemental health services. So this is very, very good for those of us who work with Medicare recipients and for those of us who work with clients who live in diverse areas. The same was also said for audio only telehealth, which Medicare has historically made this distinction with video and audio. And they said, their plan is certainly until December 31st, 2024 to keep, allowing audio only telemental health to be offered as well and covered as well. So this is all pretty good news. These were the updates on the CMS fact sheet, and I wanted to share. So I think, as I say, it's relevant to those of us who serve clients with Medicare, but also even if you don't, I think this is an interesting, canary in the mine shaft in terms of where the trends are going. And that all seems pretty promising.
And it really is kind of that crystal ball, so to speak. There's some clarity coming out of how this might roll out. And I know we do tend to get a lot of questions related to that. And I think as they make the clarities known, we will share those and continue to share those out. So we get a lot of questions about acronyms that we're using on the telehealth chat. And so we created a a slide basically that incorporates a lot of the common ones that we have used. I'm going to go through a few of them today. But for those of you wanting to download the slide or have access to that, if you go to the Trust Pharma website for the telehealth community chats, you'll notice up on the top right-hand side, there's chat resources, and you can find the acronyms there. You can also find some guidelines and some definitions there. So if you're looking for this resource, you can find it there. They might be putting a link in the chat for you right here. But I'm going to talk a bit about the acronyms so that we can make sure we're all on the same page. ASPBB is at the top of the list, and that's the Association of State and Provincial Psychology Boards. They're the group of kind of member boards of all the licensing boards from around the country and Canada. And so that is ASPPB. The next one is PsyPact, and Dr. Martin already told us what that was standing for earlier, but that's the Psychology Interjurisdictional Compact. And that's what's coming through the pipeline, and I'll have a little update about that, of helping us be able to provide services to individuals who are not in the jurisdiction in which we're licensed. IJTP is our kind of acronym for interjurisdictional telepsychology. And that's a lot to say, so we shorten it to IJTP. We also have the e-passport or APIT, and that's a certificate that when it's granted to somebody who's applied and has all the credentials for it, allows that person to practice interjurisdictional telepsychology. And APIT, which is part of that e-passport name that I mentioned, it stands for the Authority to Practice Interjurisdictional Telepsychology. You're getting a flavor. A lot of these acronyms are for telepsychology practice across jurisdictions. And what's been around for a very long time, when we were actually moving or traveling in person from place to place to do practice, was Interjurisdictional Practice Certificate, and that is the IPC. And that has consistently been issued through ASPPB. So there's a theme here of the regulatory world helping us with the tools we need in order to manage to practice in different jurisdictions in a legal manner. There is also something called the Temporary Authority to Practice, and that is TAP. At this point, we should all know what HIPAA stands for, but I tell you, even I get it a little confusing to figure out what are those two A's at the end, and are there two A's or two P's? Because that was always that there's a double letter. Which one is it? HIPAA is the Health Insurance Portability and Accountability Act of 1996. We also have talked about U.S. Department of Health and Human Services, and we shorten that to US DHHS or sometimes DHHS, depending on our conversation. PHI, which we will be talking about today, is Protected Health Information, and this comes from HIPAA, and it is the 18 protected health identifiers of information that can be directly linked back to you as a person or an individual who is seeking care. We also talk about business associates agreements, the BAA, and we talk about the Centers for Medicare and Medicaid Services, which is CMS. It's a big list.
Well done. It's a lot of acronyms. Well, and we don't expect everyone to memorize this. You know, we have this link in the chat that folks can access this durable FAQ on the Trust website that will go over those acronyms. Okay. I guess the next one isn't new news, but it has occurred since our last chat. And this relates to the end of discretionary enforcement of HIPAA that ended August 10th, 2023. So, as some of us may recall, in the context of the pandemic, now I can use this acronym, this is a nice bridge, DHHS. The U.S. Department of Health and Human Services, had said that there was going to be certain facets of HIPAA that they were showing leniency toward, and particularly this was around video conferencing and the technologies we use to see patients when video conferencing. And they basically said, hey, we know everyone's trying to do their best and see the patients. We're not looking to necessarily pursue cases against people who are just trying to see their patients. If they were using, for example, Skype, or if they were using, for example, FaceTime, or one of these products not designed for healthcare. That period has concluded. So we're back to the standard that was before the pandemic, which is using video conferencing and other telehealth products that are designed for healthcare that, offer us that BAA, see another acronym, that Business Associates Agreement that fundamentally says, we know that you are a HIPAA covered entity and we are going to behave as a HIPAA covered entity to ensure that we are an appropriate partner for the work you do. So that period's over. I mean, we knew it was coming, but it has happened. So this is just a reminder that we should all be sure we're using telehealth products that are designed for healthcare, that offer a business associates agreement, and that comply with HIPAA. I wanted to reiterate something that Dr. Martin mentioned at the beginning of our talk, and that was the upcoming National Practice Conference. On the first pre-conference day, on the 3rd, there will be a presentation by our wonderful trust risk managers on ethical, clinical, regulatory, and risk management considerations in telehealth practice. I know I'll be there. It's going to be a great presentation. And I wanted to mention to the folks who are at this webinar today that if you're going to, be coming to Washington, D.C. for the conference, I hope you will, that is a talk not to be missed.
Fantastic. And I have one last quick update related to SIPAC, and that is we're up to 40 states that have enacted the legislation. 39 of those are in effect currently. We have 2 states that have active legislation. And as Dr. Martin mentioned earlier, on November 30th, the roundtable is going to be all about SIPAC. So I noticed we've got a few questions coming in to the chat, and I am going to say, get yourself signed up for that. I know I already have, so that you can really dig in and understand some of the distinctions and current updates that are coming out related to that process and also the legislation. So, whew, that's a lot of news.
There's a lot of news. Our news section was dense today, but well, it's funny because our first topic for today that's a little more formal, I suppose, is also vaguely news related because it derives from some things that have occurred in the news in the last quarter. And so to describe the situation well, I'm going to start with specifics and then get more broad, describe some things that happened in our practice communities and sort of what it means for those of us doing telehealth and wanting to do so ethically and well. So to begin with the specifics, there was in the news, and perhaps if you are a user of some of these products in your practice, one of the more notable electronic health records that offers telehealth services integrated in their product, Simple Practice. They have a pretty big showing. A lot of folks, particularly independent practitioners, might use them to write their notes, to bill their clients, to send secure messages, and to have video conferencing appointments through an integrated platform. And as is often the way with technology companies, the company went through and updated their terms of use. Nothing terribly scandalous about that. Companies do that from time to time. However, there was a pretty big surprise when they released this updated terms of use. And specifically, they had a clause in there. There were a number of things in this terms of use that they updated, but one of the items indicated that they would have access and ownership of data related to video conferencing calls that happened on on the Simple Practice platform. So this was a pretty big surprise. And, I want to note that's not an unusual policy for a social media company. Facebook would say that when you put a post on Facebook, it belongs to Facebook. They would say if you put a video, they feel some ownership rights or they have some ownership rights there. So that's not unusual for a social media company or other types of companies like that. It is very unusual for a healthcare company because it is not consistent with HIPAA. Now, additionally, people found this out because they logged onto their Simple Practice and there was a big banner at the top that says, we have updated terms of use, and you need to comply within 14 days, or you can't keep using the product and your clients can't keep using the portal to contact you. So it's a pretty short timeline for people to digest this information, and they were not pleased. So there was pretty substantial pushback. And Simple Practice came out with a clarifying statement and said, we will comply with HIPAA. We continue to offer a business associates agreement. We will not be interacting with this data in any way that does not comply with HIPAA. So that's good. But this does raise concerns. This is a company serving healthcare practitioners, and they made a terms of use change without really great process here around compliance, because it really is in conflict with HIPAA as we understand it. So I think it calls into question how the decision was made. It certainly made people worried about, well, wait a second, what were you planning to do with that data? And, for my own part, I was asking questions like, what other decisions are you making, that I don't know about, and how can I learn about those? Now, what was interesting is on the same day that this happened, Zoom also updated their terms of use. And I won't bore everybody with the details, but the long story short is they had made standard an option on their product, a transcription option, that would not comply with HIPAA. And you actually had to actively opt out of that in order to make sure that wasn't happening and the session wasn't being transcribed. Because consider if I have a session with a client over Zoom, there's a transcribed account of that session. Well, now that's being stored somewhere. Where is that being stored? Who has access to that? There are problems, with that and with HIPAA. And so again, users are like, wait a second, hold on. So, these are the specifics. So let's zoom out a little bit. And again, there was feedback to Zoom and Zoom said, oh, okay, sorry. And they fixed it. And so it's no longer standard. So I think the outcomes so far have been favorable. These are definitely types of situations we want to keep our eye on and see what happens. And most of all, it was confusing and did not feel good to have this type of change made what seemed in a sort of strong arm fashion and a confusing fashion. But I think it inspired a lot of us to ask the question, well, hold on, what am I saying yes to? So, for me, this isn't one company or another company. I think many of these companies have things in the terms of use that may cause us some pause. But, for me, it was the question, so what do we do? And what I really take away is we continue to consistently partner with companies designed for healthcare. So, that includes Simple Practice, that includes Zoom for healthcare. So it's not an end all be all, but it's a great place to start. We consistently practice with companies that offer that BAA and that say they will comply with HIPAA. And that, we keep apprised of terms of use changes. So we don't just click it blindly. It's so tempting, because they put up a big banner window that gets in our way of the work we need to do that day. But we take the time and we try to read through it. Increasingly, there are some requirements for these to be written in plain spoken English, so hopefully it is not so jargony that it is indecipherable. We can read it and see what we think of those changes. And we have an obligation, I think, if we see something in there that we think is inappropriate, that we contact the company and ask questions. It's important to pay attention to these updates to practices and policy changes. And I want to mention that our advocate services, our risk managers at the trust are knowledgeable about these themes. So if you contact the company, if you have additional questions, that we can use the resources available to us. If you have counsel with a healthcare attorney, these are also great folks to have take a look at some of these practices, these terms of use practices and say, well, what do you think of this? Okay, I'm going to pause there. That was a lot, but I don't want people to be alarmed, so I think this is kind of a watchful waiting situation. But, for me, it just really highlights you have to read the fine print.
I think it really highlights some of the things that we're used to doing in our personal lives. Like we see we get an app, we download it, and there's like a whole lot of agreement words that we just breeze through, scroll up, click, because I want to have it on my phone right now, right? Or there's terms that we just don't understand, so we don't read it, and so we just brush past that. And I think this scenario, I think, was actually a good one, because it caused a lot of people to ask some really good questions that probably we should be asking all the time anyways, in terms of what are we utilizing these third parties to do for us within our practice, bringing in that technology to help us communicate and connect with our patients. But what is the agreement, we have with them? And I think this idea of really understanding, you do have to read it, and it might not make sense. And then you have to find somebody who does understand it, a healthcare attorney, to be able to help you better understand that circumstance. And there's a number, I've been watching the Q&A, and there's a number of folks asking, well, who's on that list? Like what companies are there? And I would really encourage folks, if you are using a video conferencing platform, you should be going back, looking at your agreement that you signed. You may or may not have read it, but you should go back and look at that and see what the updates are to that, and really dig in and start there. Because if you're using a platform, you've got an agreement, and you probably need to know what's in that agreement.
Was it time to pause and take some? I'm seeing some great questions and some great comments as well. One comment I thought I wanted to call out, because it's an excellent point. Someone noted that I'm assuming in the jurisdiction they are in, that audio only sessions have been, they're not permitted by the Board of Psychology there. I think in this person indicated in Ohio. And I think they're pointing out a really good distinction between what can be covered by federal insurance versus what our jurisdiction, might advise us to do. And they may be different things. So when we talk about what is covered by Medicare, we're really talking about, what Medicare has indicated they will pay for. But that doesn't mean that we still don't have to look to our board, look to our license as to what is clinically appropriate. So it's a really good distinction and a great point.
It is. I saw one that I thought was interesting as you were talking about the distinctions of things that are going on with video conferencing. But this is a question about a patient that prefers FaceTime and won't log in to DoxyMe, presumably the healthcare version, and what recommendations you might have for that.
Well, gosh, I would want to explore that a little bit. There's a draconian part of me that's like, no. From a risk management standpoint, I think, we want folks to use products that comply with HIPAA, that offer the business associates agreement. And FaceTime, I don't think offers, that same level of risk management. So from a risk management standpoint, I would strongly encourage the client towards using a product that's designed for healthcare. And I appreciate that may not be a concern of theirs, but they're not the HIPAA covered entity you are, and it's your license, it's your risk. But I'd want to know more. I'd want to understand why FaceTime. Is there an access issue? Is there, is this a clinical issue? Is this an access issue, or is this just a preference? And it's something I would want to understand a bit better. I know there are schools of thought that would say, well, as long as you put it in the informed consent and you really document all this and you really, indicate that they understand the risks and so forth, but I think this is one of those, I'm not of that school of thought, because I think this is one of those circumstances wherein we have a superior product. There was a time that they were not user-friendly and they were pretty hideous, and I think it is challenging. I mean, the other thing that occurs to me is if we're using FaceTime, that means there has to be an endpoint on the provider side for FaceTime, typically an Apple phone or an app, I suppose, on another phone. And, I'd want to make sure that that endpoint is, I don't want, for example, to FaceTime on my personal phone. So, I'd want to make sure that I have an appropriate endpoint, use my work phone, keep those things really separate, because what I, on my personal phone, I have a terrible habit of like bumping the FaceTime button. Too many things can go wrong. So keeping those, quite separate. But truthfully, it's something I probably wouldn't do. And unless there was a really compelling conversation around access or something like that, that I just didn't well understand, if this really just was, well, gosh, I like FaceTime better, I would work really hard to get that patient on a HIPAA compliant platform.
Yes, I think you highlight a few other kind of endpoint considerations of that it's not just about the platform, but it's also about where you are accessing the platform from.
Yeah. I mean, they could certainly do from their phone Simple Practice or one of the others, but that there's more security involved, and there's more, frankly, flexibility on my end as to where I can reasonably take that call. Okay, I saw another good one. I saw a short one and a long one. I'm going to do the short one first.
Okay.
Talked about Medicare updates for telehealth. What about allowances for insurances like Blue Cross Blue Shield? And it's such a great question. It's one we wish we could answer because I think this highlights the manner in which often the reason we talk about Medicare is it's a massive national provider, carrier for insurance. B, it is often as Medicare goes, so go other insurance companies. So it's often I'm just thinking cannot think of the right word, but the person
Leader.
Thank you. Leader is a very good word that sets precedent, for what telehealth policy will be for other companies. And so the problematic thing here is that even within a company like Blue Cross Blue Shield, you can have variation in policy on coverage when it comes to telehealth. Now, we saw in the context of the pandemic, things shored up a bit where it was, we saw more consistent coverage. But as I understand it, things are back to being, it's better than it was before the pandemic, but it's not as reliable as it was during the pandemic that telehealth will be covered. So unfortunately, you really do have to contact the individual carrier and sometimes even the individual policy type, to understand what is covered.
The nuances are a bit more detailed.
Yeah. I saw one in a class that I teach, students were debating the benefits and disadvantages of using telehealth compared to seeing clients in person. Questions regarding effectiveness, client populations, and treatment modalities were raised. I wondered what your thoughts about this are.
Such a great question, and a great question to be exploring with the conversations with the students. I think we're seeing some really intriguing data that's coming out. We saw the start of it with the pandemic in terms of even very difficult client populations in terms of engagement in in-person therapy, that we really saw a very consistent and or improved engagement in therapy when we had to transition to a telepractice model. So I think we're starting to see some of those. Do you have any details, Sarah, in terms of specifics to dig into?
I think the question, I kind of put this in buckets. There's a question of clinical appropriateness, and that gets a lot into provider preferences. Where am I comfortable providing telehealth versus not? Do I want to do CBT over telehealth, but I do my DBT in person? How comfortable am I managing emergencies remotely? What my testing practice and my assessment practice may be harder to transition. We'll talk about that in a moment. There's some other things I do. And then, I think it gets into patient preferences. And I think that, we saw in the pandemic also a lot of data about racial disparities in telehealth. And while in some ways we were doing a great job doing outreach to patients, we also saw other widening gaps in care access. And I think it's an area we're just starting to explore and understand. But I think it's a great question. I'm wondering if maybe that will be something on a future talk we could dig into even further. But to me, it kind of breaks down into clinical appropriateness, what the provider wants to do and what the patient prefers. and has access to, technology infrastructure. Do they have a computer? Do they have, reliable internet? Do they have an endpoint that's appropriate? So there's a lot of, there's a lot of baggage that comes with a solid telehealth appointment, and, really being responsive to the need of the individual.
And I think there's one other piece, and that's the transition during care. If you start in person and transition to tele or vice versa, that there's a whole other mixed kind of milieu to consider as well. So
yeah, it's a great point. And that could go back and forth.
Should we jump into some HIPAA documentation
Um,
surrounding telehealth? And
sounds great. I'm looking at our time, and yes, we
know. I will make it short and sweet because I know you also have some things to talk about on this topic as well. And then we can wrap up maybe with some more questions. We've had questions come in the past related to HIPAA audits and what all we might want to consider related to documentation. And if HIPAA brought us anything, it has to do with very specific details related to documentation. I think the idea of making things into documents so that those could be shared, whether that was, initially in paper and now electronically. And so as I'm talking about documentation, I'm really talking about the things that we are writing out, identifying out, putting in the patient record, however that ends up looking. And now we actually have the summary of sessions that may be accessible for patients as well. But the bare minimums of what the guidance of the Department of Health and Human Service Center, which is kind of the rolling out group of HIPAA information to the masses of medical providers. We need background information, we need diagnosis, we need patient information, we need the symptoms, we need to document any tests, assessments, and kind of the results or the documentations related to that, and then our treatment and future plan. And I'm just going to highlight in those categories some of the details that HIPAA is very particular about. And many of us using electronic health records, this is all kind of already populated in a way. You've either made a template for this, or it is asking you to enter this information. But the background information for the patient includes their name, that of the provider's name, in addition to details related to the session. So things like date and length of time, the modality. So yes, you do have to say you're providing a session through telehealth. If this is a child, patient, parents might have been present, how long they were present, who was present, if it's a collateral information source that may be coming into session. The diagnosis of ICD-10 or DSM-5 codes that are related to the diagnosis you're treating or suspect, or a rule-out diagnosis. And any observations of the presenting concerns, behaviors, attitudes, affect, what you're noticing of a patient, symptoms that they report experiencing that impact day to day, and whether things may have improved from the last session. Like I mentioned about testing and assessment, you really have to outline those results of the relevant tests, what the name of the assessment was, when they completed it, how they completed it, any authorization to release information if it's coming from, for example, a checklist from a teacher. Any of those types of things needs to be entered into the record. And finally, any notable treatment plan that you may have modifications to, any new goals that might be formed, and the date and time of your next session with them. So these are the things that when audited, these are the items that the auditors will be looking for and are recommended to be included. There is a distinction between a progress note, which is what all of these things should be documented in, versus psychotherapy notes, which are the more protected, more private record related to perhaps things that you don't want included in those progress notes that potentially a patient may have access to down the road. And I always think about writing those progress notes as things that inform me about the clinical nature and these details of care, but that other people might be reading, including the patient, patient's parent, another provider who might request the information down the road or need it to carry on services, or a medical provider who it might be relevant for. So those are just things to keep in mind. And I will, in the sake of time, toss this over to Sarah, because I know you have some things to wrap up on this topic too.
Yes. So, I think I appreciate we're talking about HIPAA audits and, those that will sort of be good record keeping and help prevent, any problematic outcomes should we have to go through that. I wanted to complement that with some information about the clinical side of telehealth documentation. We received some questions about that last time and wanted to circle back to those, what to document and why in my note. And really, 3 things I wanted to highlight. And this first one we can include in every note, but we certainly want to have at least once in the record, in a patient record, which is why telehealth, and so I often encourage to make sure that's in that intake note. Some folks elect to copy and paste it into every note, but this is one that I think is adequate just to put in the intake note, personal choice. This has changed over the years in response to the prevalence of telehealth. I think that in the beginning, it was kind of a bit of a long story as to why telehealth, because it wasn't a very standard practice, but we want to understand, the availability of alternative in-person care. We want to understand, is this patient preference? Is there a clinical utility to doing this in the home with the patient? We just want to explain why we're doing this and document our reasoning. Again, this is quite different than when we did this 10 years ago, and this was less of a standard of care, but still, it is a valid point that we want to make sure we include in that intake note. Now, in every note, we're going to indicate that this is a telepsychology appointment, and we're going to include information related to an emergency plan. We want to make sure that for each patient, we have a bespoke, unique emergency plan that includes information such as where the patient is located, the patient's address and telephone number, and any notable impairments they might have to emergency access. Are you calling someone on the top of a mountain? I've worked with folks in, pretty remote areas. And if I was going to call 911 for them, well, they're an hour away from emergency response. So understanding that early and often is a good idea. We want to make sure that in our separate documented emergency plan, we have an overview of what will occur in case of emergency. So what's going to happen? Am I going to contact emergency services, stay with the patient, and so forth? We want to make sure that we are identifying a local support person if there is one available, someone who could go unlock that front door and let emergency services in. And if there is a person who's appropriate, in advance, we want to collect a release of information to contact that person. Now, I know that in emergent circumstances, we have a little bit more permission around themes, but why not, do it right first time, identify that person early and, get that release of information. When possible, I like to identify the patient's primary care provider and any relevant additional treating providers. And I want to outline with the patient how I would follow up after an emergency. What would you expect to happen after emergency services came? How are you and I going to be in communication? And again, this is not an emergency. We're talking about a clinical emergency. And this is different from like a technology emergency or, gosh, my internet's out. Those are different circumstances. So we want to differentiate that with our client. And this emergency plan is documented. We discuss it with the client. And usually this is something I recommend we do as part of that intake process. So I always have a longer documented emergency plan. And then I kind of have an abbreviated version that I copy and paste into most notes. I like to have it right at the top saying, this is where the patient's located. This is how to contact them. They are aware of the emergency plan. And finally, we want to make sure we have informed consent for telepsychology. Now, a lot of folks say, well, of course I do informed consent. I know to do that, not a problem. But this is actually a separate, distinct form. And I want to encourage folks to go to the Trust website. There's a really great template there that will guide you through the necessary components of informed consent for telepsychology that reviews the unique risks and benefits of seeing clients in this way. And as always, we are being responsive to changes. So we get people's informed consent for telepsychology. We ensure that we think this is appropriate, and we've written down why telepsychology, but this is an ongoing assessment. So the person may be appropriate at the beginning of care doesn't mean it always stays that way. And so we pay attention, to changes in our client's symptoms. And if something changes and we feel they're no longer appropriate, well, we're documenting that again. So these are some of the things we like to see in our telehealth documentation from a clinical side that really help us manage our risk and frankly, I think lead us through a good decisional process of taking care of our patients. Okay, I saw a lot of questions, Margot, about simple practice saying, well, wait a second, what are we saying about simple practice?
Good.
So my best understanding, and I'm not an attorney, but I will say my best understanding is that they are still, simple practice is still offering a business associates agreement. They are reporting that they will comply with HIPAA. And I'm keeping an eye. So I would say, I don't believe the counsel is to run out and change your provider today if you do use simple practice, but I think it is something that it's worth continuing to follow and continuing to see how they deal with this issue. So far, they have said, well, we're not going to use that data in any way that doesn't comply with HIPAA. So, what can I do except believe you, but I think that the fact that they made this terms of use change that would have put them at odds with it, I think was problematic. So I think a lot of us are keeping our eye on the situation, and we'll just kind of continue to see what the company has to say about this. And if you have questions, you can always contact their customer support and say, well, what are you doing about this? And believe me, they have received a lot of feedback on the topic, so they should have answers for you.
I saw a lot of questions coming in related to the HIPAA documentation and outlines, and where could folks find those outlines of things that would be important to include in your notes. Those can be found. Actually, the Trust has an amazing repertoire of templates, some of them very specific to states, because as you remember, sometimes the HIPAA requirements are a little bit more stringent related to your state, that some states are kind of silent on this. Some states have their own requirements. So you can find that outline and or outlines for this on the Trust website as well in the resources.
Great. Well, I'm cognizant of our time. I think we have one more subject. Should we hit our last subject and then?
For sure. Let's take a dive in.
All right. So last time we received some questions about assessment practices, and assessment remains a really challenging area in telepsychology. I think implementation of remote assessments brings just unique considerations. Specifically, we want to think about the availability of norms in remote administration environments. And it's one of those areas that we don't always have non-inferiority data. We have a lot of data saying that for clinical interventions, clients get better, much as they do in in-person conditions. We have a lot of data that say rapport is there, client satisfaction is there. Testing remains an emerging practice area. So I think that we want to be really thoughtful about, when and where to do this, because on the other hand, as we know, at the heart of telehealth is access. So providing remote assessment is also an opportunity to get assessment to people who might not get it otherwise. So it feels a little bit like the old telehealth days where we're having to straddle these themes, but just a few points for consideration briefly. First, I always want to think about is how formal is this assessment? How will this be used? Is this a survey, a self-report survey to inform my clinical impression of a client? My client seems anxious. I would like to explore that a little bit, or is this testing done in a forensic case, to do with child custody? I think we want to, in particular for legal circumstances, all our circumstances deserve high standards and, to be clinically appropriate. In legal circumstances, if we do not administer tests in the canonized way, we risk, having our findings invalidated. An attorney needs say, well, hey, this person didn't use the assessment tool as indicated. The norms are not appropriate for the circumstance, and then all our good work, may not be usable. So, we want to think a little bit about how it's going to be used. Is this our only opportunity to do the assessment? Will it be combined with in-person components such that it would be appropriate to divide? Because again, some measures are more easily adapted, that self-report survey versus, a test with blocks and manipulation and things like that. That's much harder to adapt, especially without a remote person on site. Sometimes you can have a psychometrician on site with the patient. That's kind of a rare privilege to have that. So we want to think a little bit about how adaptable the measures we are using. And I do think common sense comes into play. Again, is this something that has been codified by the test maker? Increasingly, test publishers are offering online versions. So is there something already established? Or is this something that's just a really hard fit for the modality? We want to ask that test creator what's available. We want to look for peer-reviewed articles on the subject. How are people addressing this? And whenever possible, we want to use the correct norms for the correct environment. And in your report, we want to acknowledge all of this. So if there's been any administration of a test other than its standard administration, we always want to report that in our clinical notes or in an assessment report that we are writing. Okay.
There's a number of questions about where do we put all this documentation, meaning how much goes into our progress note for the session versus what you just mentioned. We might generate a report that's a bit distinct from that progress note for the session. Also, some of the questions had to do with the informed consent for telepsychology, and if that needs to be in itself a separate document versus can it be part of the informed consent? So just clarity.
I think of it as a separate document, but honestly, if you just wanted to have both documents, you just be sure you get signatures on both is what I would say. It depends on what you're using to administer this. But I think it's just make sure you have the content, but I do like it being a separate process. But I think as long as you have signatures for both, we're in good shape. Well, I want to thank you so much, Margot, for joining once again to chat. I know we're about at our time. And thank you to everyone for submitting these wonderful questions. We didn't get to all of them today, but please know we read all of them and we will use them for our next chat. I see that Dr. Martin has joined us again, and I think that means it's time for us to hand it back over.
Well, it flies by so fast. So thank you both for allowing another time for us to chat together, and I look forward to the next one.
Yes, well, so do we. And goodness gracious, you covered an awful lot of stuff. And just by looking at the volume of questions, it certainly shows how engaged people are and how much they really do need this kind of direction that you provide. So we're very, very honored to have both of you serve with us to help psychologists and our policyholders. So thank you for another wonderful trip down the technology telechat lane. So appreciate it very much.